tēnā koutou, tēnā koutou, tēnā koutou katoa. Me tīmata mai ta tātou kaupapa I te himene, he hōnore, ka haere tonu ngā krakia, ka mutu I kona mo tēnei wahanga mōku, nā reira tēnā koutou, ta tātou himene, he hōnore. He hōnore, he korohia, mangaro ki te whenua, whakaro, paie, ki ngā tangata katoa, te atua, te piringa, tōku oranga, he honore, he korohia, mangarongo ki te whenua, whakaro, paie, ki ngā tangata katoa, te atua, he piringa, tōku oranga, ake, 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 amine. Tā tātou krakia, ko rangi nui, ko papatua nuku, ka puta ko rongo, ko tāne mahuta, ko tangaroa, ko tāpiri mātea, ko tūmatauenga, haumi e tike tike. Tōko nā te rangi ki runga, ko papa ki raro, ka puta te ira tangata ki te whai ao, ki te ao marama. Ko ia e rongo e whakaria ake ki runga kia tīna tīna. Hara mai te toki, haumi e, hui e, tāiki e. Tā tātou krakia ki te atua. E tō mātou mātou I te rangi, kia tapu tō ingoa, kia tai mai tō rangatiratanga, kia mea tia tāu e pai ai, ki runga ki te whenua, kia rite anō ki tō te rangi. Ho mai kia mātou aia nei, hei taro mā mātou mō tēnei rā. Murua o mātou hara, me mātou hoki e muru nei, I o te hunga e harana kia mātou. Aua hoki mātou e kawea, kia whakawaia, engari whakaorangia mātou I te kino. Nau hoki te rangatiratanga, te kaha me te kroria, ake, ake, amene, amene, kia ora tātou.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. Me tahi, he honore, he gloria ki te atua, he mongorongo ki te whenua, he whakaro pai ki ngā tangata katoa. Tēnā koe whaia ane mō tō karakia, o tēnei pō, he mihi, he mihi, he mihi. Te tangata whenua o tēnei rohe, e nā mana, e nā reo, nā hoi whā. Rā rangatira mā, tēnā koutou, tēnā koutou, tēnā koutou katoa. No mai, hari mai, piki mai, whakato mai, ki te whenua o te parafo, ki te whare o te konihera o whangarei te ringa parawa, ki te kaupapa o tēnei pō. te kaupapa o te tiriti o Waitangi, te kaupapa o ngā tamariki o Aotearoa. Ngā mate, o tēnā marae, haere, haere, haere. Te honga ora, tēnā koutou, tēnā koutou, tēnā koutou katoa. Once again, I would like to firstly acknowledge the karakia within the whare this evening and acknowledge you, Whaia Ani, for leading us in karakia. Tēnā pia. On behalf of Manaia PHO, it gives me great pleasure and a privilege to welcome all of you here this evening for what is becoming a significant annual event on our calendar within whangarei and within the wider health world. On your behalf, I welcome all guests who have travelled here this evening, and in a special way would like to welcome our guest speakers this evening, Matu Moana Jackson and Professor Immunization. On this, the eve of the weekend where annually we commemorate and remember the signing of Te Tiriti o Waitangi, we are privileged and we're honoured and actually impelled to continue the conversation, to continue to understand, and to continue to apply Te Tiriti to our lives and work. While this weekend as a country, the focus is more intense on Te Tiriti, for those of us who live here in Te Tai Tokerau, the focus is every day. This is where we live. It's who we live with, and it's how people live that keeps this focus alive in our minds and hearts and actions. 6 out of every 10 children born today in Northland are Māori. 25% of our children here are living in poverty. All children are the treasures, are ngā tohanga of Te Tiriti, are the treasures that the treaty is committed to protect. So why are we here tonight? Why do we do this every year? In the health world, we have a number of different types of organisations. There are organisations which we call mainstream, and they focus on the health of the population. And they're staffed by incredible, dedicated professionals doing wonderful things on a day-to-day basis. We have Māori-specific health organisations. And one of the great phenomenons of New Zealand over the last 20 or so years has been the emergence and the strength of these Māori organisations. And I particularly acknowledge tonight our three local Māori health organisations who are here this evening. Ngāti Hini Health Trust, Kia Ora Ngāti Wai, and Te Haoranga o Ngāti Whātua. And then there is a third organisation, or groups of organisations. And these I call partner organisations. Organisations that bring together or come together under the partnership framework of Te Tiriti o Waitangi. Māori and non-Māori joining together to work for health, well-being, equity within our community. Manaia PHO is one of these organisations, and there are few in the country. Manaia PHO is committed to Te Tiriti, and Te Tiriti underpins all relationships and permeates all activity within the organisation. Some of you may know the poem by Robert Frost, A Road Less Travelled. 2 roads diverged in a yellow wood. and sorry I could not travel both. And be one traveller, long I stood, and looked down one as far as I could, to where it bent in the undergrowth. And I took the one less travelled by, and that has made all the difference. The road of partnership under the framework of Te Tiriti o Waitangi is indeed the road less travelled. At first, it appears to be a frightening, somewhat scary road to travel. But once one takes the first step and actually breaks through the undergrowth, we discover that beyond the undergrowth, there are in fact other travellers who are seeking, challenging, encouraging, inspiring, leading, nurturing, sometimes following, that we are not alone. Most of you here tonight are these people, and I want to acknowledge every single one of you who has taken the time to come here this evening, taken the time and energy on a Friday evening before a long weekend to give of this time to be part of the ongoing conversation. I acknowledge you all most sincerely. Over the years, we have invited significant leaders and rangatira who are travelling down the road less travelled to join us to be part of the conversation on the eve of the Treaty of Waitangi commemoration. And last year we were energised and nourished by Cindy Kiro, Dame Salmon and Tariana Turia. Tonight it is our great privilege to welcome two other outstanding rangatira within Aotearoa New Zealand, Moana Jackson and Immunization. Both of these people, Moana and Ines, have travelled especially to be here with us this evening. They have left personal commitments and family to give of their time for us this evening. And on your behalf, I want to thank them for being here. Both are outstanding leaders within our country. And I would like to first of all introduce Professor Immunization to you, who is going to be our first speaker this evening. Ines is personally known to many of us. Ines is a Professor of Paediatrics, Child and Youth Health at Auckland University within the School of Medicine, and is a consultant in paediatric medicine at the Starship Children's Hospital, which involves clinical work, teaching work, research work. In 2003, Ines was awarded the New Zealand Order of Merit for services to paediatrics, and in 2007, the Health Research Council Lilly Medal for her research leadership. Professor Asher is co-editor of Trying to Catch Our Breath, The Burden of Preventable Breathing Diseases in Children and Young People. Professor Asher is on the steering group of the National Child and Youth Epidemiology Service, which selects, collates and disseminates timely and accurate information on the health of our young children and young people in New Zealand, and is a contributing author to the Child Poverty Action Group's cornerstone report, Left Behind: How Social Income Inequalities Damage New Zealand Children. As chair of Child Poverty Action Group, Ines is a courageous, inspiring and passionate leader for the fight for all children's rights within our country, for their health and welfare in this land of ours. It gives me great pleasure again to welcome Ines to our gathering this evening.
Ko te tiriti, ko te tiriti, te tiriti o Waitangi. Ko te tiriti, Ko te tiriti, te tiriti o Aotearoa. Hiki te ki runga, hiki te ki runga. Mō tuhake, rangatiratanga tuku iho. Rangatiratanga tuku iho.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ke te mihi ahau ki a koutou a Ngāpuhi. Kia ora Chris mō tō mihi. Kia ora Ngāri Rei. Kia ora Whaiani. Kia ora tō koutou rangatira o te turi moana. He honore nui ki te kōrero i tēnei hui. Nā tā tātou roro kia ora nā tamariki. Thank you very much for inviting me to speak, and thank you, Chris, for your introduction, Nairi for organising everything, and your fabulous leadership here too, Whaiani, Moana for your great leadership in the area of law, and with our small baskets we can keep the children well. E hara taku toa e te toa takitahi e nari e toa takimano e, and I'd particularly like to acknowledge the Child Poverty Action Group's website there if you don't already know it, and also the Paediatric Society of New Zealand, whose slogan is health with our children, wealth with our nation. So we know that we are the best in the world at rugby. We are the best in the world, and every New Zealander got behind that. We put all the resources we wanted to. We committed everything as a nation and as rugby people to be the best in the world. And that's our ranking statistics out of 25 countries. These are our rankings this is our ranking for health. New Zealand children's health and safety compared to other OECD countries. And you'll see here we're 24th out of 25th, not first out of 25th as we are for rugby. So what would it take for us to become first out of 25 as we are for rugby? In this lecture, I'm going to talk about child rights, and I think you'll be pleased because that was what was advertised. Child health outcomes in New Zealand, international comparisons and inequalities within New Zealand, determinants of health, a triple jeopardy, and briefly the way forward. So in the New Zealand context, we have four documents and conventions in which we can frame our child rights and we should look to for direction. And the first I want to talk about is the United Nations Convention on the Rights of the Child. And this convention was formed in 1990 and New Zealand ratified it in 1993. And this convention is, while quite lengthy, in essence, these bullet points summarise the relevance to health. That children have the right to an adequate standard of living, the right to a free education, rights to shelter, health, medical services and measures to prevent illnesses, the right to appropriate care for mental and physically disabled children, and that governments have responsibility to ensure these rights. So that being the case nearly 20 years ago, how are we doing? Well, the United Nations Committee on Children gets reports from governments and non-government organisations in New Zealand to monitor what we're doing. And in February, just a year ago, they reported on our progress. And compared to the last report in 2003, they said the positive developments were the amendment to Section 59 of the Crimes Act 1961, not using reasonable force to discipline children, increasing expenditure on children, policies to support families and address family violence, abuse and neglect, and a number of legislative initiatives and ratified international instruments. So this looks quite a good picture, and it is good that some areas have improved. But then they went on to say there were serious concerns about New Zealand where progress had been minimal. The disparities experienced by Māori children and children in poverty and vulnerable situations, these were their concerns about the lack of progress in addressing their previous recommendations, both as a general point and reiterated throughout the specific areas covered, such as child labour, juvenile justice, adoption and policy coordination. And they were concerned about the failure of the government to remove its reservations and harmonise its domestic laws with the United Nations Convention. And they remained alarmed at the high prevalence of abuse and neglect of children in the family. So that's where we are with the United Nations Convention on the Rights of the Child in New Zealand. We have a Human Rights Act, 1993, which in essence states that everyone has the right to freedom from discrimination. Well, we had a major onset of discrimination against children in New Zealand in 1996. And this was the introduction of the child tax credit by the national government in that year. And Annette King at the time, in opposition, stated, sorry, before I go on to read this through, the child tax credit was giving money, a tax credit to parents who are in work, but not giving it to parents if they weren't in paid work. And she said correctly that what this national government has done is create two classes of children, the children of beneficiaries and the children of people in work. We've never before had a public policy that labels children and puts value on a child whose parents have a job and a lesser value on a child of a person who's on a benefit. But that is exactly what this national government has done with its announcement. If one is the child of a beneficiary, one is not as valuable as the child of a working person. I would just go on to say that Labor have not reversed this. In fact, they've cemented this as the in-work tax credit, as it's now been renamed, somewhat misleadingly, but it's because it's a child tax credit if the parents are in work. And it's worth $60 a week, which you'll know how important that is to families who are struggling. But it only goes to families where a single parent is in paid work 20 or more hours per week, or two parents work 30 or more hours per week between them. So you can see there that single parents also are disadvantaged compared to the two parents, and if they work 19 hours, they won't get it. This discriminates against children of parents on a benefit as they're not eligible. It was intended to lift some beneficiaries into work, but this has failed as a policy. So the Child Poverty Action Group, in recognising this discrimination, laid a legal complaint with the Human Rights Commission in 2002, and after a lot of convoluted legal processes tried to stop us to take the case. And finally it was heard by the Human Rights Tribunal in 2008, and they found that this in-works tax credit, as it's now called, constitutes real and substantive discrimination against children. And but they then went on to say that this discrimination is justified. So the Child Poverty Action Group wasn't going to take that last point lying down. So we went to the High Court, but they agreed with the findings of the Human Rights Tribunal. So we're now taking this to the Court of Appeal, and we'll go to the Supreme Court if we need to. So if anyone wants to find out more about that, go to the Child Poverty Action Group site. But this is an example of discrimination against children that began in 1996 in this country. Again, it was discrimination against the poorest children. We have, as another background rights document, the Declaration on the Rights of Indigenous People 2007, which was endorsed by New Zealand in April 2010, and you can read that there. But of course, our most important piece of legislation in regard to Indigenous people is the treaty, which in regard to health was to give an equal opportunity for health for New Zealand children, Māori and non-Māori. So how are we faring in this regard? Well, I'd just like to start with, you probably heard this last year from Anne Salmon, because I'm quoting her now, but let's just think for a moment about what was Māori health like before the Europeans arrived, or as they arrived. They had excellent health and freedom from child abuse at that time. To both Cook and Banks, these people, Māori people, were healthy in the highest degree. I think we have to say that's excellent. Compared with Europe of the time, children were rarely hit, meaning two things. They weren't hit in Māori, but they were hit in the European context. The women seemed to be good mothers. The men were also very fond and kind to their children. And I've heard Anne speak since she wrote this book, and she said every single thing she's ever all the evidence points to these being true facts. Contrast this then with the compilation by Paparangi Reid and Bridget Robson in 2007 talking about Māori health at this time. There are consistent, comprehensive and compelling disparities in health outcomes and exposure to the determinants of health. Despite the strength of these long-standing health inequalities, they do not create dismay, disbelief or horror. They become expected. This acceptance and normalisation of inequalities provides an excuse for government inaction. I have a personal connection with Tūhoi from having worked with them in 1977 and having been through my great-grandfather having a connection with the Presbyterian mission at Mongopohatu. So I'm just going to give a couple more examples around child well-being in regard to Tūhoi. And we are inspired by Judith Binney's wonderful book, which if any of you are interested at all in Indigenous people anywhere in the world, not only in New Zealand, it's a wonderful exemplar of the effects of colonisation and the uphill struggle against it and the consequences of it, and yet a very and showing the strength and resilience of Māori people. So, from her work, we know that in January 1866, there was this large tracts of land here were confiscated by the Crown illegally, and this land that was taken was the best agricultural land, 14,000 acres, and most of the land behind the confiscation, was this area here, was unsuitable for farming, being inland hills, valleys and gorges. And this is Mongopohatu I referred to, and I'm going to mention Te Whāiti in the next slide. So the Tūhoi were forced away from their arable lands, they were stolen off them and had to move back here, and this resulted in a series of famines. And there were a lot of deaths in the famines, and the children being the most vulnerable. This is just from Judith Binney's book about a famine in 1897 at Te Whāiti, I showed you on the map. Tutu Kangaho, a Tūhoi chief whose 7-year-old granddaughter died of measles at Te Whāiti, cried out during the procession to bring her home to Mongopohatu. This dying of our young people is a new thing. In former times, our people scarcely knew disease. They died on the battlefield or of old age. These diseases which slay our people were brought by the white man. They brought the epidemics, the influenza, scabs, the measles. Michael King, in commenting about access to health care at a later time, in this book by Te Purio, wrote, in regard to Waikato Māori, in 1906, he wrote, there were few doctors who would attend Māori patients, and no hospitals to admit them to, and no preventative health measures. It's just over 100 years ago. The nearest hospitals were in Auckland and Hamilton, but they really took Māori patients and didn't want to. He went on to say, in his Penguin History of New Zealand, that for a long time the official attitude to problems of Māori health and welfare was to ignore them. The Auckland health officer in whose district the bulk of the Māori population lived, stated in 1911 that Māori health should be of concern to Europeans, but only because the unchecked spread of Māori diseases could eventually lead to Europeans contracting them. As matters stand, he wrote, the native race is a menace to the well-being of the European. Now just contrast this with the lament from Tangi Kangahau, only 14 years older, about his 7-year-old granddaughter. Fortunately, there have been massive improvements in Māori health since then. However, there's still room for improvement. I would just like to pause now and just acknowledge the tremendous work done by Manaia PHO and many organisations and people in Northland, and I think that you're leading the way in so many ways, and I admire and salute the fantastic work you're doing. So the things I'm saying aren't applying to the direction and the fantastic work we're doing, but we do need to reflect on the whole of New Zealand and our history. So we can appreciate that in recent history there have been hardened racist attitudes against Māori by some doctors. And I have to say there is prejudice in our European whakapapa. Back to Tūhoi. Unfortunately, institutional racism outside of the health service also occurs and is present today. And this impacts directly on child well-being, which is why I'm speaking about it, of course. At Mangapōhatu, on the 2nd of April 1916, police entered the peaceful community to illegally arrest Ruakanana and others, and 2 Tūhoi men were killed. Despite the police claiming in court that while they were present in Mangapōhatu, women and children were unrestricted, it is clear from this photograph, here with the armed policemen standing by the women and children, that under armed police guard that was not the case. 91 years later, on the 15th of October 2007, only 4 years ago, Tūhoi children were again frightened by extreme police behaviour, this time at Ruatoki, on the other side of the Uraweras, but still in Tūhoi territory. Police dressed like the man in this photo confronted children in a variety of situations. On the side of the shed in Ruatoki, it says, I cried because we were hungry and scared, 5 years old, 15th of October 2007. This is likely to be reporting the words of one of the children, as reported to Howard Broad, Police Commissioner at the time. And this report said, one man said he counted 43 police officers surrounding the house where he lived with his partner, his 4 young children, and his father and his partner, and all of these police dressed in military attire, like I showed you before, had guns trained on the house. A loud hailer was used in the early hours of the morning, ordering the occupants of the house to come out. They did so, to the shocking scene of being confronted by these bandido-like persons pointing guns at them and their home. The occupants were immediately detained. Sometimes they were directed towards a designated area where guns were continuously trained on them and were told not to move from that spot. In the other cases, they were placed in a shed or moved to a police van. These prisoners, mainly women and children, were kept under armed guard and detained for varying periods of between 3 and 6 hours. The children particularly were terrified. Their clothing, blankets and food were inadequate, and they were not permitted to re-enter their homes to obtain more. On both of these occasions, police failed to protect Māori children from the effects of their police-induced trauma. Since these episodes, in the episode in 2007, police have taken no steps to ameliorate the effects of this trauma on the children. Treaty of Waitangi? Surely we can work together better than this and protect our most vulnerable citizens. I'm now going to turn to some health statistics and a bit more boring down into how we're doing in child health in New Zealand, and want to show you how we're doing compared to other countries in regard to the conditions in which I work most commonly, being a medical paediatrician, serious bacterial infections and respiratory diseases. And if we just look here, these are the diseases here. These are a rate of 1 given to other countries in the OECD, and this is the New Zealand relative rate. And you'll see at the peak of the meningococcal disease epidemic, our rates were 5 to 17 times other countries. Rheumatic fevers, nearly 14 times other countries. Serious skin infections, 2. Whooping cough, 5 to 10. Pneumonia, 5 to 10. And bronchiectasis, 8 to 10. Massively bigger than other comparable countries. Horrifically bigger. But as Paparangi Reid said, we kind of got used to it, and it kind of sounds normal, but it really ain't. What about inequalities within New Zealand? So this is looking at similar diseases, a few more here, and common or important infections and other diseases. And here's the least deprived neighbourhoods in New Zealand, and the rates are given as 1. And then we look at the rates of these are hospitalisations for these conditions, and look at them in the NZDEP 10, the 10% of the most deprived areas, and see the rates here, not just a doubling, but rates, 5 times, rheumatic fever, as you know only too well in this area, nearly 29 times, bronchiectasis, these frightfully damaging, lifelong damaging diseases, 16 times. So really high rates, huge inequalities. And if we look by ethnicity, we see that a very stark differences there too, with the same diseases listed here. And for the European rates here, Māori rates double, 4 times, rheumatic fever very high, and Pacific even more horrendous rates for some of these diseases, really horrific. Asian Indian, which are becoming a big part of our childhood population, the only thing that they stand out really high is around TB, which probably reflects the countries of their origin and TB rates in those countries, but otherwise they are doing pretty comparably to European. Oh, gosh, a few years ago, Helen Clark was talking about closing the gaps, and we've all been beavering away. But, unfortunately, some of these health inequalities are increasing despite the passage of time. And I want to draw your attention to the fact that rheumatic fever inequalities are increasing. So here we have all the people in New Zealand who aren't Māori and Pacific, and you see the rates from 1996 to 2005 are actually slowly going down, whereas Māori rates are going up and Pacific rates are going up, and of course they're stupendously higher than the non-Māori, non-Pacific rates. So we've got increasing health inequalities. This is pretty new information, but some of you may have seen it. It came out in September last year from Liz Craig, data analysis from the Children's Social Health Monitor, looking at conditions, hospital admissions for conditions that had a social gradient, and seeing what was happening with them over the last 10 years, 2000 to 2010. And we've got them by ethnicity here, Asian, actually slow but catching up and actually going up slightly. Remarkably constant level for European, New Zealand European children. But for Māori, 50% higher to start off with, and look, the gap is widening. And then Pacific kids way up again, even higher. And the gap is huge. So we have increasing inequalities on the backbone of very high inequalities. So that's a pretty concerning picture. So these problems have complex origins, which we call the determinants of health. This isn't just about one thing that is causing us or one thing that can fix it. So let's just reflect on that for a moment. What are the determinants of health? And Professor Sir Geoffrey Rose from London, who's one of the gurus in public health and preventative medicine, in 1992, in his lovely little book, The Strategy of Preventive Medicine, said the primary determinants of disease are mainly economic and social, and therefore its remedies must also be economic and social. Medicine and politics cannot and should not be kept apart. By politics, what we really mean is policies. It's the policies that are the key, not a particular politician. It's what goes into policy that is the key. Another thing that's very important to note is maternal educational achievement is the single most important determinant of child health. And so immediately we see here that we've got social, economic and education as key in all of this. Closer to home, we had a National Health Committee led by Professor Robert Beaglehole of our university. In 1998 they brought out this document, Social, Cultural and Economic Determinants of Health in New Zealand, Action to Improve Health. And they said, social, cultural and economic factors are the most important determinants of health. There are deficiencies in income, education and housing which contribute to ill health and the marked ethnic disparities. There are immediate health gains to be made by applying information and knowledge that is already available. And to my assessment of their recommendations, probably the single thing that's changed in this 14-year period has been that we've actually starting to get the immunisation rate right. But there's little else has changed, unfortunately, despite this call to action by authoritative figures. Now, I'm wanting just to give you a little bit more of my take on some of these issues. I became particularly engaged about this area, this issue of why we've got such big health issues in children when I saw this graph. Now, this here is looking at serious skin infections, and you'll notice here serious skin infections were ticking along at the same level, and suddenly between 1994 and 1998 there was a doubling of serious skin infections. Now, all of those of you who are doctors and nurses will know to get a doubling of a disease in a 5-year period, whoa, what the heck is happening? And if doubling in 5 years, that's almost unheard of for something like this, maybe an epidemic or something, but something that's not of an epidemic type of disease. So I thought when I saw this, there must have been a tipping point at that time that's tipped our children to getting more hospital admissions for serious skin infections than they've ever had before, and way exceeding any other comparable country. What's going on? And it wasn't long before I pieced together my own story, which I'm going to put to you, about the triple jeopardy for health of many children in New Zealand. And I joined this Child Poverty Action Group to kind of learn a bit more about the broader aspects of health. And what we do know is right now in New Zealand, there are, depending on how you measure it, there's 22 or 26% in poverty by an income dollar definition. But if you look at it another way, there's 19% in severe or significant hardship. So whatever way you look at it, there's at least about 1 in 5 children in New Zealand are lacking some of the necessities, and we're talking about having to put off going to the doctor because they can't afford it, not having food on the table when they need it. The other second jeopardy, so these numbers got mucked up in my reformatting of the slide. 2, housing, cold, damp and overcrowded, and primary healthcare access. So let's just take through those briefly. So defining poverty in New Zealand, we're talking mainly about relative poverty, which is exclusion from the minimum acceptable way of life in one's own society because of inadequate resources. And that is things like expecting to eat every day, a nutritious diet, expecting to go to the doctor when you're sick, that's the kind of thing. You know, you could argue that there may be a few children living in absolute poverty in New Zealand without running water, electricity, adequate shelter. I don't know. You would know, but certainly relative poverty is what we normally talk about in New Zealand. As a paediatrician, how I define poverty and how I look at it is that you have insufficient income for these things that are essential to health. And these things that are essential to health is getting healthcare, which includes transport there, doctor's fees, prescription costs, hospital parking, etc. Having enough income for the nutritious food, having adequate housing, not crowded, damp, cold or too costly, having adequate clothing, shoes, bedding, washing and drying facilities, having access to education, costs of transport, stationery, school donations, exam fees, school trips. And I haven't even mentioned luxuries like sports here. So if you're in poverty in New Zealand, from a health perspective, it's because when you have all your income coming in, it isn't enough to cover all those things. You have to choose between necessities, and that's what poverty really is. So I'm going to go back to this tipping point, and when we look at the graph of that serious skin infections, and we put it on this graph here of poverty, we see that there was a tipping point for child poverty also at the same time, and so there's a strong correlation between what we're seeing for the admissions for serious skin infections and for the increase in child poverty. This is here from 1980 up to 2010, although these levels of child poverty here were unacceptably high, so 10 to 15%, they went up to double, and they're staying up nearly double. And that's, the first thing we should try and do is get our poverty rates back to this level here, because this is a shocking trajectory. There were lots of things that happened around this time here, and let's just look at those. Before we do, I'm going to look at this by ethnicity, and if you thought that was a bad picture, look at this one by ethnicity, and this doesn't go quite so far out here, but this is Europeans. You see Europeans here, they've got a bad trajectory. But look at Māori here, and Pacific here. So everyone was clustered not too far apart here, and then spread out, increasing inequalities, with Māori and Pacific taking the brunt of it, but everybody affected. And we have an extraordinary paradox in New Zealand. So just before I go back to the people, there's a lot of discussion about who is in poverty, and of the kids in poverty, currently about half of them are in beneficiary families, but about half of them are in families where there's one adult working full-time in paid work. So we've got a problem of really low wages as well. But there is a focus on beneficiary families because they are often in even deeper poverty, and they form at least about half the group of children in poverty. So I'm going to look at those for a minute. So here we are. We've got here, I'm just going to take you through these graphs. Here we've got the population percent. We've got all people, which will include children, on an income-tested benefit. These are on market wages, and these are the elderly. You'll see that very different graphs here. So let's just take you through. These are the hardship tests. So this is severe hardship, significant hardship, some hardship, fairly comfortable, good, very good living conditions. So very bad, and this is the group here that we're incredibly concerned about. Now, if you look at the elderly over 65, they're all supported by a benefit too. They're supported by a superannuation benefit. And look how well they're doing. So we've got a real paradox in New Zealand. We've got benefits for the elderly that keep them out of poverty, and benefits for young families that are driving them into it. So we've got a double standard in New Zealand that we should examine closely. So there were several changes in policy adversely affecting incomes of low-income households with children around that 1991 time, around the whole period actually, but there's a lot of changes around 1991 in particular. But overall, we've got low wages and relatively high taxes for the low-paid. Family income support's been inadequate for low-income families, been no indexing of family income support for 20 years from 1989 to 2008. In 1991, the universal family benefit was abolished. And for beneficiary families, in 1991, the benefits were cut by 21%, and they've not been restored relatively. So what was sort of an adequate benefit is just, 20%, 1%'s been knocked out of that, and no wonder people are struggling to make ends meet. And then this child tax credit, which was excluded, from which the beneficiary families were excluded. Jeopardy 2, housing. The two main issues, you'll be very familiar with this, I'm sure, in your area, are crowding and quality, cold and damp. And so crowding is driven by families having to double up because the accommodation is too expensive. and was uncovered as a major issue for our health with meningococcal epidemic, where it was found that you got an increased risk of meningococcal disease, a marked increased risk as you got crowded. It was the chief risk factor for a meningococcal epidemic. So in New Zealand, in regard to the quality, 300,000 homes are wooden, uninsulated, damp and cold. And the problem is with that is that cold, damp houses can cause ill health, and they can cost a lot to heat, and that's unaffordable for low-income families. So when you look at that severe and significant hardship group, most of those people aren't heating their homes at all. So they're living in very cold, damp homes with no winter heating. It was only in 1978 that insulation for new housing became compulsory. We know that improving housing quality does help health. It's intuitive, but there's now been several New Zealand studies proving that point, and let's just quickly look at those. Since 2001, there's been these research programs, and they've shown that improving housing quality, which means insulating it and making it bigger if it needs to be, heating it with good heating, quality heating. So we've got improved self-rated health, self-reported wheezing, improved days off school and work, and fewer visits to GPs, a trend for fewer hospital admissions for respiratory conditions. Another study showed 37% lower rate of housing-related potentially avoidable hospitalisations, and the largest decrease was especially for respiratory conditions in children. And another study showed children with asthma significantly reduced their symptoms, days off school and healthcare visits. So there's immediate gains to be made by attending to housing. Jeopardy 3. I feel a bit in jeopardy here talking about this to primary healthcare people, but I will anyway. Primary healthcare access. So I just want to focus on 2 points here. And one is the cost of general practitioner visits for children in New Zealand as a whole. And I'm wanting to show you that in hours, which is 25% of the week, in most of the rest of the world with which we compare ourselves, it costs nothing to go to the doctor at any time in hours, whereas in New Zealand it's patchy. But it's often free now, and it's mostly free for children under 6 in hours. Out of hours is a huge problem, with us being really out of step with other parts of the world. And I'd like to congratulate Manaia PHO for the step you took, I think 2 years ago now, where you cut your after-hours fee to $5, and that was a New Zealand leading initiative, and I'd like to congratulate you for that. So to carry on with a bit more information, our current Minister of Health obtained this information from the Labour government about the kinds of costs that people were incurring for under 6-year-olds. 50 clinics charge more than 15, 19 charge this even for those enrolled with the PHO, and 10 clinics charge at least 41. And we all know what $41 can buy for the family for food for the week, and they have to make a choice between these types of... It doesn't seem to make sense that you've got, if we've got such a huge burden of acute infections in particular, that we have a cost between the child getting a need for a doctor and but not being able to afford that cost, given that for a low-income family that is an issue. I want to just comment on another issue, which I know you're doing very well up here, and in fact nationally we're doing very well now, but we've been very tardy on this nationally. If we look back, New Zealand immunisation rates, which have now become a success story, which have not been for 2 decades. So if we go back to 1991-92, our average immunisation rate was 56%, quite shameful. And the target then set by the Ministry of Health was to have 95% by 2000. Let's go forward to 1999, it was up to 63%. They said they'd have it 90% by 2003, well it became 77.4 by 2005. And they said let's make it 95%, but didn't give a target. They introduced the National Immunisation Register, that didn't change anything. But it was only when the Minister of Health, I think, correct me if I'm wrong, said you've just got to do this, we've just got to do this, and we are. Suddenly we've got 90% by July 2011, and the target's going to get higher and it's going to get tougher, like immunisations on time. So we actually decide, it's taken us a long time to decide to do something about immunisations, but immunisations are a really good way of reducing disparities, and we're obviously having trouble doing it other ways, so this is one thing we can do to reduce disparities. And really, internationally, immunisation rates are thought of and considered as a measure of the national commitment to primary health care for all children. So it's fantastic that we're now doing so well, and I congratulate those of you who have heard some fantastic stories up here. So it's just great that that's coming along so well now around New Zealand. So I'm not going to give you a whole lot of recommendations. I'm just saying that the way forward is to prioritise our children. They're our future. We need to adhere to our, if we adhere to our national rights commitments, we'll get it right. And I think we need to work together, and that's what we're doing here tonight. We need to work together towards eliminating disparities. Because the future of New Zealand depends on the well-being of every child. Aho heiti heiti pōnamo. Thank you.
Unuhia te rito te hara ke keihia te ko mako e ko. Whakatai rangi tia rere ki uta rere ki tai. Nau e ki mai he aha te mea nui. Maku e ki atu he tangata, he